talking about the data itself, right now, the SunRISe-1 trial had 4 arms, right? We're going to kind of report on 3 of those arms. The first arm was a combination of the TAR-200 plus cetrelimab. Second arm was the TAR-200 alone, and the third arm was the cetrelimab arm alone. Now, looking at the 12-month estimated CR rates, we're seeing approximately 57% CR rate in the TAR-200 alone arm, which is actually slightly superior to that estimated in the combination cetrelimab plus TAR. And the cetrelimab alone arm is roughly about 22% CR rate, which is tracking, in line with other IO therapies in similar patient populations in previously reported trials. So, one, what do you think about the data? And two, what do you think about the monotherapy being superior to the combination?
I was happy with it because I was hopeful that we could potentially get away from systemic therapy for this disease state, just because the potential for toxicity is so much different than anything intravesical. So I think it was refreshing to see that we're on the right track. Something in the bladder is going to work better than something systemically that has the potential to cause much more toxicity.
I was also really excited about it from a logistical standpoint because there are many, many, many more urology practices in the country that are going to be comfortable with an intravesical therapy than with a systemic therapy and with an infusion. And so, from a how do you get the drug to the patient standpoint, one of the nice things about the TAR, it comes in a small little package, it's shelf stable for years. I mean, this is something that even far-flung clinics can stack up on a shelf and know that they're going to use it, whereas if it had been superior with the cetrelimab, that would have presented a bit more of a challenge. So I was actually happy about it.
I think the thing that's interesting to me is that the TAR-200 device gives medicine that is not immunotherapy, but I think, for those of us that have been doing this for a while, Brian and I go way back with the Scipio cell T days, is there's a concept of antigen cascade. So in some ways, the chemotherapy becomes immunogenic. So I think that may be one of the reasons that it's there for a while and that you're getting this over this period of time, that you have such superior results, that as the cancer cells are destroyed by the gemcitabine, that there's you're provoking some sort of immune response, because otherwise you have no way of explaining why it would be more durable and better than the immunotherapy that's given every couple weeks. And I second everything else was said about the tolerability and ease of use of the medicine. Using any type of systemic immunotherapy is something that I really would try and not want to do a lot in my clinic, just because I own those patients when they have side effects. This is light years better.
Yeah. And when we look at the CR 12 months, it's dramatically better than anything that's in the marketplace right now. And when these trials are designed, a lot of these trials talk about 3-month CRs, right? And so I'd like to get the group's thought about, what's the implication of a 3-month CR to you guys, if anything, and how important is a 12-month compared to a 3-month CR? Gene?
Yeah, so I have a little bit of a soapbox here on this one because this is a fundamentally different disease state than a lot of the oncology spaces, where if you have someone who has metastatic disease, they're incurable, and that's the mindset that a lot of medical oncologists are bringing to the table. 3 months, 6 months, 12 months, 18 months, those are all very, very important. This is a space where we do have an excellent curative option in cystectomy, but it is a morbid operation, and most patients would rather keep their bladder than undergo a cystectomy. So if we're kicking the can down the road 3 months, that's not clinically meaningful.
Yeah.
If we can potentially get a high complete response rate so that we can tell patients, no, there's a good chance that you're going to be keeping your bladder for the long run, not just delaying cystectomy a year or two until you're older and sicker and maybe not even cystectomy fit, that's a much bigger win in this space. And so I think that this is one of the first therapies to really clear that bar, where you don't feel like you're just delaying the cystectomy that they're probably still going to need with a 20% CR rate at 12 months. And now we're really entering into territory of, are we more durably curing you?
Yeah, we've come a long ways. Valrubicin was used really, really very infrequently just because of that. Yeah. We all were like, why? So incrementally better. Now I agree, we're getting to the point where, okay, that's meaningful, because the fear is that you're dinking around with a bladder cancer and then this patient escapes and develops metastatic disease, and then we all feel bad.
Yeah, I think there should be a distinction between the CIS patient population and the papillary population with this conversation too.
That's true.
Because I believe that they're kind of inherently different disease states, and your risk tolerance may be different in those folks. But this was a heavily pretreated patient population, right? They had far over at least 12 on median or more, in a series of intravesical treatments. So they were the appropriate patient to kind of come onto trial in this space. And the results are compelling. I mean, they're paradigm changing. Brian, what are your thoughts?
Obviously, every patient wants to keep their bladder. I mean, and it is a life-changing morbid operation. So I think I'm excited by this data. I want to see more. And then I have yet to participate in the TAR trial, so I would like to take it for a test drive. So I'm still sitting on the sidelines watching.
While Melhoff's kicking the tires, Gene, you're taking it around the track a little bit. You've been on trial with this, and I know you've had a fair amount of experience. Tolerability seems to be manageable in your practice. Response seems to be consistent with what was reported at ESMO 2024, in your opinion?
Yeah, I think that data is consistent with what we've seen on the ground. And in terms of the test drive, because until you do it, it's hard to know exactly how it's going to fit into your clinic. We had a fair amount of trepidation with the first patient that we put a TAR into. And after you do it a couple times, it's a under 90-second exchange. I mean, scope in, grab it, pull it out, catheter in, put it in, pull it out. We put them in a 20-minute procedure slot just because there's some MA time and they have to get unchanged and prepped and all of that. But this is something that any clinic that performs cystoscopies can very easily operationalize.
Our experience has been the same. They just go into a normal cysto clinic spot. That's any other cysto would, and it doesn't really add any extra time.
Yeah.
So let's drill down on that a little bit, kind of operationally. This is something that docs are doing in your practice, mid-levels are going to be doing. Are you going to be surveilling them simultaneously, which is, I think, one of the benefits here, personally, to me. One. Two, you're looking at 8 visits over 6 months. Is that a lot, too much, and 8 procedures in that same period of time?
I think the procedure itself is very advanced practice provider friendly, but I think we just have to be cautious because this, assuming this gets approval, this is going to be in a heavily pretreated patient population that I still want to have in our group, our docs, eyeballing the bladder periodically, and as they get used to using the device. So I think that's the one thing I just have a little bit of concern about. I think the second thing that's interesting to me is J&J has a lot of experience with devices, and I think there's only a potential opportunity to make the device better as it relates to tolerability. They're kind of working on some fun things that are going to make it, hopefully make that so, because we don't know on some of the side effects how much that is related to the actual device going in, and is there some room for improvement. It's already pretty good, so I think there might be an opportunity to, as it gets out into the real world and there's lots and lots of people using it, to give some feedback to J&J and say, hey, do this way or do it that way, and use best practices to make it better.
Yeah, we talked about maybe even developing pathways or a tips and trick sheet or troubleshooting to try to mitigate side effect profile. Tim, you're going to say?
Yeah, I think there's a sweet spot between the physician and the APP. I love the fact that you can do surveillance every 3 weeks, but we'd all agree you probably don't need to do surveillance every 3 weeks. So I think it is a perfect procedure for APPs to do, and I think that's coming in a lot of different disease states in our practices. Yeah. Here before long, half the urology workforce in the country is going to be an APP and not a urologist. And so they are going to start doing some of these technical procedures, not diagnostic procedures, but technical procedures, prostate biopsies, et cetera. So I do think that this lends into that pathway for the future, but I agree with you. You still need urology hands-on at some point for the surveillance and monitoring, but it doesn't have to be every 3 weeks.
I think from a bandwidth standpoint, depending on how you structure it, I think we calculated that it was an extra 8 to 10 cystoscopies in that first 12-month period. And if you do any volume of bladder cancer, let's say you have 50 new high-risk bladder cancer patients per year. This isn't necessarily SunRISe-1, but for SunRISe-3, BCG naive, if that reads out positively, you're adding potentially 500 scopes to your practice if you only see 50 new high-risk bladder cancer patients per year. I don't have the bandwidth for that, so APPs are going to have to step in.
Facilities or the staff or
great. It's going to require some rethinking. It's going to require some rethinking for sure, but I think that we're going to need to have the APPs involved in at least the exchanges. And I agree, I want to be the one looking for the diagnostic cysto.